Hello out there, I'm Dr. David Siu. Today I'm going to show you how to perform cardiovascular examination. In each patient, clinicians have to integrate all the information available from history, examination, and investigation in order to draw the conclusion about the structure and function of the patient's heart and the systemic and pulmonary vasculature. While often students will be preoccupied by the anxiety of difficult auscultation, at the end of the day, they fail to analyze the clinical finding in a logical way. So my advice is that auscultation is only the way to confirm your previous examination finding and not the only way to show the final diagnosis. Before we start, we have to obtain consent from the patient, followed by adequate protection of the patient's privacy. In case the patient is of opposite gender, we have to have chaperone throughout the whole examination. In general, we will divide the examination into two main parts, the general examination and the cardiovascular examination. And for the cardiovascular examination, is including the examination of patient's arterial system, which mainly pulses, and then venous system, mainly the jugular venous pressure, and lastly, the heart itself, precordium. And we should proceed for the general examination now. For the general examination, before we touch a patient, we'd like to have some general observation for any syndromal features like Down syndrome, Marfan-Lloyd features that may suggest some underlying cardiovascular diseases. And then we would like to examine the patient's face, followed by his hand and then the lower limb. So let's start from the face. So we will look for a pallor. We will touch the patient's face and then pull up the lower eyelid to look at the color and then to confirm whether it's pallor or not. And in this case, we do not observe any pallor. And then we'd like to observe for cyanosis. 可唔可以伸條脷出嚟睇下咧 ？Okay, 唔該晒。So for cyanosis, we have two different forms. One is called central cyanosis that you usually observe in the tongue of the patient. And the other one is called peripheral cyanosis that will be observed in the patient's periphery, including fingers and also toe. Peripheral cyanosis can sometimes as a result of cold weather leading to vasoconstriction even in normal individuals. However, central cyanosis that observed in the tongue is always pathological. Then we will move on to examine the patient's hands. 可唔可以睇到對手咧 The general examination of the hand in the case of cardiovascular system, we would like to look for certain things that are peculiar to the cardiovascular system, including finger cupping, which may suggest if underlying cyanotic heart disease or infective endocarditis, as well as any other features suggestive of infective endocarditis, such as sphincter hemorrhages, ostenoke, and also genuine lesion. And for cupping of finger, first of all, we like to observe from the sign of each finger to look for any evidence of loss of angle between the nail and the nail bed. And we observe for both hands and every single fingers. And then we would like to have more detailed examination for cupping. We will usually fix the patient's distal part of the finger, the distal phalanx, with our thumb and index finger from both hands. And then we try to move the finger like a seesaw. If there is excessive movement of the nail bed, it's usually indicating any soft tissue deposition underneath the nail, indicating cupping. And we will test for all 10 fingers. 好，睇睇呢邊嚇。唔該晒。And there's no finger cupping. And then we'd like to look for sphincter hemorrhages. We observe each fingers of the nail bed and make sure there's no such lesions. And then we will look for ostenoke, genuine lesion in the palm. And there is none. Okay, 唔該晒。We will skip the radial pulse for the time being. We will leave it to the cardiovascular examination, and then we will move on to the lower limb of the patient. For the lower limb, we generally look for evidence of pitting ankle edema, which may be a feature of right heart failure. We usually observe the pitting edema from the medial side of the leg, just above the malleolus, using our thumb. Usually we press down from the area just above the medial malleolus for 3 to 5 seconds, and then leave it. And then we check for any dimple formation over the area. In case there's ankle edema detected, we'll try to look for the upper limit of the ankle edema, and then we test for the other side as well. In some patients, you may also be able to find cupping of toes in certain cyanotic congenital heart disease, and which is absent in this patient. After completing the general examination of the patient, we will proceed for the cardiovascular examination. The first part of the cardiovascular examination is the examination of the patient pulse. We usually start off from the radial pulse. The radial pulse is situated at the radial head, at the base of the thumb. We usually palpate it using 3 fingers. After you detect the radial pulse, you like to observe several things. First, the rate. We usually determine the rate by counting the number of pulses over a period of 15 or 30 seconds. If the pulse is totally irregular, we'll count for a longer time, for example 30 seconds. If it's regular, you can just count for 15 seconds. And in this patient, the pulse is irregular, and the rate is around 78 per minute. After determining the rate, we will proceed to determine the rhythm of the patient. Determination of the rhythm somehow is very like singing a song. We will likewise detect the radial pulse. After you can detect it, you started to follow the patient pulses and counting it like 1, 2, 3, 4. And usually after 5 to 6 beats, you will be able to anticipate when the next beat will come. If the beat really comes at the time that you anticipated, then more or less this is regular. If the beat fails to come at the right time, you may want to count again and to catch the rhythm again. And likewise, if it's not arrived at the same time, it is most likely to be an irregular pulse. And in this patient, his pulse is irregular. The differential diagnosis of an irregular pulse including atrial fibrillation, atrial flutter or atrial tachycardia with variable block, multifocal atrial tachycardia. And occasionally, for patients with very frequent ectopics, can also mimic a totally irregular pulse. After determining the rate and rhythm, we go into the characteristic. Usually, we like to determine the characteristic of the pulse together with the volume in the carotid pulse because it has the closest proximity to the heart. But for the radial pulse, we would like to detect whether there is any possibility of collapsing pulse. What is collapsing pulse? Collapsing pulse is a pulse with a rapid upstroke and a rapid decay, like this. Rapid upstroke and a rapid decay. In contrast to normal pulse, it's usually a gradual upstroke and then gradual decay. We'll usually like to observe it using our palm over this particular area, and we'll cover the radial pulse with this area. In order to exaggerate the physiology of collapsing pulse, many times we would like to raise the patient's arm, and usually the collapsing pulse will become more obvious. As collapsing pulse many times indicating several pathological conditions of the heart, including aortic regurgitation, patent ductus arteriosus, atrioventricular malformation, or sometimes in patients with hyperdynamic circulation. There is an alternative way to detect collapsing pulse in the setting of aortic regurgitation. So we will detect the patient's radial pulse using our left hand, just as before. When we detect the radial pulse, we gradually release our grip until the point that we just cannot feel it. So that means at this particular stroke volume or pulse volume, we fail to feel anything. That means we're setting 0. And then we raise the patient arm with our right hand. While keeping this relationship, our hand and the patient radial pulse at the same steady position. Because when we raise the patient arm, there will be excessive runoff back into the left ventricle if there is presence of the aortic regurgitation. So for the next heartbeat, the stroke volume will increase. So we will be able to detect a reappearance of the radial pulse. And this is an indication of collapsing pulse, suggesting underlying aortic regurgitation. After detecting the collapsing pulse, we will check for radial delay and radial-femoral delay. For convenience, we will usually like to put the patient's hands in this position, and then we feel both pulses at the same time. And there's no radial delay in this patient. And while with our left hand still with the patient pulse, we will move our right hand to the patient groin to look for radial-femoral delay, which is absent in this patient. When it's present, it's usually indicating aortic coarctation or aortic dissection, or sometimes in patients with severe peripheral arterial disease can also have radial and femoral delay. After finish the arterial examination, we will proceed to the neck of the patient. This is the sternocleidomastoid muscle from the medial third of the clavicle run all the way posteriorly and superior to the mastoid process. And underneath this muscle is the carotid artery at the same line, and then lateral to it is the internal jugular vein, which is the target vein we like to observe for jugular venous pressure. We should not observe for the external jugular vein, which usually over this particular area commonly will be more easy to observe, but it is not accurate to reflect the right atrial pressure. In this patient, there's a pulsation up to this point that you can observe. And normally we will measure this jugular venous pressure from the Lewis angle. The jugular venous pressure is not obvious in individual with a normal right atrial pressure and is usually below the clavicle. In patients with pathophysiology leading to increase in right heart pressure, right atrial pressure, the jugular venous pressure will be elevated and become observable at the neck. In case we are not sure whether the pulsation is a jugular venous pressure or a carotid pulsation, we have several maneuvers to distinguish them. First, the jugular venous pressure is visible but not palpable. In contrast, the carotid pulsation is usually palpable because of the arterial pressure is much higher than the venous pressure. Second, the jugular venous pressure can be obliterate by putting your fingers against the clavicle over here. But this is not the case for carotid pulsation. The jugular venous pressure will change with patient posture as well as the inspiration or expiration. However, carotid pulsation remains the same. And in this patient, the jugular venous pressure is at this level. If we lower down the band, it will become more obvious. 我哋搞低張床下。可以望過多少少。And you can see that the jugular venous pressure is more obvious in this case, simply because we lower down the band and make the pulsation more visible. In case you still cannot differentiate the carotid and the jugular venous pressure, you may try to do the hepatojugular reflex. How to do that? We usually put our hand over the right costal margin of the patient and then provide some pressure onto it. 有啲唔舒服下。Okay. And you can see the JVP rise from here all the way up to here, simply because when we provide pressure upon the liver, we're increasing excessive blood back to the right heart. And this increase in P-load will be loaded to the right atrial pressure. And so it rise the overall pressure and make it become visible in the neck. Then we would like to take the opportunity to examine the patient's carotid artery, which can tell us the volume as well as the characteristic of the pulse. The carotid artery, as mentioned, is lying underneath the sternocleidomastoid muscle. We would like to palpate it at the level of the thyroid cartilage. Because the volume of the carotid artery is much bigger than other pulses, it usually can be detected with just one finger. So in this case, we'll use our thumb to detect it. We'll use our left thumb to detect the right carotid artery and using our right thumb to detect the left carotid artery. And never palpate the two carotid arteries at the same time because this may lead to decrease in blood circulation to the brain. So we'll do it like this over here. And then using the other thumb over the other side. Then we will proceed to the examination of the heart itself, the pericardium. In order to have a good examination, we like to have adequate exposure of the patient's chest. We will look for obvious chest wall deformity, including chest wall depression, kyphosis, and scoliosis. And then we look for scars, which indicate previous cardiac surgery. For example, left thoracotomy scar, which is absent, or missed sternotomy scar. And also we would like to look for any obvious pulsation. And then we will go ahead to the palpation. For palpation, we will have to detect the apex of the patient, followed by parasternal heave and then any possible through over the chest wall. For the apex palpation, we aim to first look for the location of the apex, to look for any displaced apex, usually indicating left ventricular dilatation, and then the characteristic of the apex. In normal individual, the apex is in the fifth intercostal space, mid-clavicular line. The intercostal space can be start counting from the Lewis angle. Then we start off from the sternal angle and then move down to the first elevation, which is the Lewis angle. And just next to it, this is the second intercostal space. And then followed by third, fourth, and fifth. Mid-clavicular line can be measured from the medial end of the clavicle to the tip of the acromion. And halfway between it, this is the mid-clavicular line. We usually start to locate the apex by spreading our right palm over the left side of the chest wall over quite a big area in order to increase the chance that we pick up the apex. Then we like to pinpoint the apex location with the tip of our fingers. Okay, it's over here. So we count from the sternal notch, second space, third, fourth, fifth, and then the mid-clavicular line is here. So you can see that the apex of this patient is displayed laterally around 3 cm from the mid-clavicular line, indicating that left ventricular dilatation. After determining the location of the apex, we like to determine the characteristic of the patient apex. We will put our palm back to the patient apex and try to feel it. I can feel the apex pin is over quite a big area here. Usually, there are 5 types of apexes that we can detect clinically. First, normal. Second, pressure overload, or in other words, heaving. Third, volume overload, or in other words, thrusting. Fourth, tapping, which is very typical for mitral stenosis. And lastly is dyskinetic or double, usually in the case of hypertrophic obstructive cardiomyopathy. So, what is a heaving apex? Heaving literally basically means a sustained lifting force. Presume this is the palm that you're detecting the apex, and this is the apex. This is a heave. It's a sustained lifting force over your palm. It's usually indicating pressure overload. For example, in case of aortic stenosis, severe systemic hypertension. You can imagine in patients with aortic stenosis, where the left ventricular outflow tract is very narrow, the heart had to press in a sustained way to push out all the blood from the left ventricle to the systemic circulation in this way. As a result, when you feel the apex like this, it feels like a sustained lifting force. Another kind of apex is called volume overload type of apex, or thrusting. It occurs in the setting of mitral regurgitation or aortic regurgitation. In those situations, the volume overload is due to the presence of a low resistance chamber for the blood to run off during the systolic phase. So the apex is more or less like come and go in a very rapid manner, just like this. This is the palm that you're going to detect the apex, and this is the apex. It comes and goes in a very rapid way and over quite a diffuse area. In fact, this patient apex is of a diffuse type. I can feel it is over quite a big area and hitting me in a come and go manner, like this. Another type of pathological apex is called tapping. In fact, tapping is very similar to thrusting in the sense that it's also come and go very rapidly, like this. But somehow, the area of tapping is much smaller than thrusting. It's usually as small as a coin. This is usually indicating mitral stenosis. After determining the apex, we like to determine the parasternal heave. Parasternal heave is a heave around the sternum, over this area. How to detect it? We usually put our palm over the patient's sternum, and then left our body weight onto the patient's chest wall. If the patient has a parasternal heave, you can feel that a force pushing your body up from the patient's chest. And when it's present, it's usually indicating either right ventricular hypertrophy or left atrial enlargement, which is absent in this patient. And then we like to look for thrill, which is a palpable murmur. It's a small vibration over the chest wall. We like to feel in the apex, tricuspid area, pulmonary area, and then the aortic area. Now it's come to the last part, auscultation. Before we take out our stethoscope, let's reanalyze all the data we have before we listen to the patient's heart. First, the patient have an irregular pulse, most likely due to atrial fibrillation. This suggesting that this patient may have underlying valvular heart disease or heart failure. And the patient's GBP does not elevate, indicating that there may not be any right heart failure. The apex of the patient is dispaced, that means the patient has a left ventricular dilatation. And the nature of the apex is a diffuse type, indicating that the patient may have a volume overload type of heart condition. For example, mitral regurgitation or aortic regurgitation. In both situations, it can lead to subsequent atrial fibrillation. However, we did not detect any collapsing pulse or Corrigan sign during the examination of pulses, so the chances of severe aortic regurgitation is not high. So quite likely, this patient may have mitral regurgitation leading to left ventricular enlargement as well as atrial fibrillation. So now, we'd like to confirm our suspicion using our stethoscope. For stethoscope, there's two signs. One is called the bell. The other sign is called diaphragm. We will usually use the bell to listen for the low-pitched sound, and the rest of the heart we will using the diaphragm to listen to. For the low pitch sound, we usually refer to the apex where we look for any mitral stenosis murmur. First, we will locate the apex again, which is here, and then we'll put our stethoscope right over the apex. In order to time the cardiac cycle, we would like to have the reference. We usually will take the cardiac pulsation as the reference. So we usually will use the cardiac pulse to time the cardiac cycle. Whenever you feel the pulse, this is the systolic phase. For the low-pitch murmur in mitral stenosis, sometimes it will be difficult to detect. So we may want to turn the patient to the left side, make the heart closer to the chest wall to ease our examination. 好啊，市場啊，可唔可以瞓側少少啊？好，向左邊係啦，多少少，係啦，好好嚇，可以再多啲喎。哦 ，OK 得。And then we put the stethoscope over the apex, and then count the cardiac cycle. In fact, in this position, you can see the patient apex beat more clearly. You can see her pulsation beating over a very wide, diffuse area. In this position, you can see the patient apex beat is become more prominent since it's getting closer to the chest wall. And you can see that it's beating in an irregular way, and the pulsation is quite diffuse over quite a big area. And then we will use the diaphragm to listen for the rest of the heart. First in the mitral area, and then to the tricuspid area, the pulmonary area, and then we will ask the patient to sit up, to lean forward to look for the left sternal border again for any early diastolic murmur. 好，可以坐起身下市場。好，唞啖大氣，噴晒出嚟。唞啖大氣，噴晒出嚟。If you detect any murmur, you like to look for radiation both in the axilla as well as the carotid artery. Then we will take the opportunity to extend the patient back for any bibasal crackles. 聽聽背脊下，好，唞氣，呼氣，唞氣，吸氣，呼氣，再嚟吸氣，呼氣，吸氣，呼氣，吸氣，呼氣，吸氣。呼氣 ，OK， 好，可以瞓返低啦。During the auscultation, I detect the first heart sound is muffled by a pansystolic murmur, best heard in the apex, grade 4/6, with radiation to the axilla, and the second sound is normal. Taken collectively, we detect atrial fibrillation, a dyspaced apex with a diffuse type characteristic, as well as a pansystolic murmur best heard at the apex which radiates to the axilla. The overall clinical diagnosis will be a patient with mitral regurgitation with left ventricular dilatation, and also atrial fibrillation. I hope I have demonstrated to you a rational approach in cardiovascular examination, allowing us to come up to the diagnosis in a logical manner.